Hello, everyone. Welcome. Again, my name is Sherry Scales. I'm a Regional Gift Officer with the Providence Foundations of Oregon. And on behalf of Providence, thank you for joining us today for Doc Talks. These presentations bring our best and brightest clinicians to you so that you can learn how best we're doing in revolutionary treatments, research, and community support efforts, all that are fueled by philanthropy, and how these are bringing more hope to patients. The Providence family of organizations has one common vision: health for a better world. Here in Oregon, our Providence hospitals, clinics, and physicians, along with several globally recognized centers of excellence, are working together to bring that vision to life. And today, we're going to learn how two of our centers have joined forces in a presentation called Cancer plus Heart Disease, a 1-2 punch. With gratitude for an extremely generous tribute gift, we're going to hear about the Jack Loacker Center for Cardio-Oncology. This is a collaborative program of Providence Cancer Institute and Providence Heart Institute that seeks to help patients who are undergoing life-saving cancer care keep their hearts safe. And it's just getting started. And now it is my honor to introduce Dr. Michael Layoun, Medical Director for the new Jack Loacker Center. Born and raised in Portland, Oregon, Dr. Layoun completed his medical training and his cardiovascular medicine fellowship at OHSU before joining Providence in 2020. Under Dr. Layoun's leadership, Providence has begun working in earnest to prevent and treat the adverse cardiovascular effects of cancer therapies, also to conduct research on how these adverse effects arise, identify who is most vulnerable to them, and advance how they may be prevented or reduced. Please join me in welcoming Dr. Michael Layoun.
Sherry, thank you so much for the incredibly kind introduction. Let me pull up my slides here. All right, I hope everyone can see that okay. Sherry, I really appreciate the kind introduction. My name is Dr. Layoun, Michael Layoun. I'm one of the general cardiologists with the Providence Heart Institute. And our doc talk today is titled Cancer plus Heart Disease, a devastating 1-2 punch. The focus of our talk today specifically is going to be looking at this marriage between the Providence Heart Institute and the Providence Cancer Institute and how we help that oncology population manage heart disease and prevent the potential risks of toxicity to the heart through various different treatments. Specifically, we're going to go through an outline looking at the field of cardio-oncology. We're going to start with epidemiology and survivalship trends in both a cardiovascular and oncologic population. We're going to define what cardio-oncology is and basically how this field has been borne out. We're then going to look at some specific cardiotoxic cancer treatments, or I should say treatments that have the risk for potential toxicity to the heart, as well as the effects of radiation on the heart. We'll then look at certain types of blood cardiac biomarkers that we use in this field and various types of cardiac imaging. And then lastly, we'll talk about where the field of cardio-oncology is going and our efforts to build a cardio-oncology center here in Providence. So let's start with the epidemiology and survivalship trends in these populations. So let's first start with cardiovascular survivalship trends in the United States. And we know that from the most updated data from the Center for Medicare and Medicaid from the American Heart Association, over the last decade, there continues to be a rapid and uptrending prevalence of cardiovascular disease and cardiovascular risk factors, with almost 50% of the US population either living with some form of cardiovascular risk factor or cardiovascular disease itself. On top of that, over 6 million US adults are now living with heart failure, and 30-day rates of mortality after acute heart attack remain quite elevated. As I alluded to a moment ago, data from the Center of Medicare and Medicaid continue to show that cardiovascular disease is a leading cause of death across all ethnic groups, with cancer falling right behind. Now compare this to oncologic survival trends in the last year. So last year, we saw 1.9 million new cancer cases and over 600,000 cancer deaths occurring in the US alone, according to the American Cancer Society data. Almost a fourth of those were attributed to lung cancer. And we're predicted to have over 8,400 cancer deaths in Oregon alone this year. However, the thing that's been quite reassuring over the last decade or so of oncologic survivorship trends is they continue to improve. Cancer patients are living longer thanks to modern advances in drug-targeted therapies, novel therapies, new screening and surveillance programs as well. But as these cancer patients continue to live longer and continue to survive through their cancers, we are now starting to see an uptick in cardiovascular trends in this population. This comprehensive review published back in 2019 looked at survivorship trends in oncologic populations and showed that in the US, more than 1 in 10 cancer survivors will actually die from cardiovascular disease itself. Highest in bladder cancer, prostate cancer, and then breast cancer. On a global scale, this more recent study published 2 years ago, looking at over 7.5 million cancer patients worldwide, showed that those patients living with cancer or who had been treated for cancer had significantly higher odds of dying from cardiovascular disease compared to the general population. When we start zooming in on some specific cancer populations, we look at breast cancer through the Women's Health Initiative, a large registry looking at women's health, especially in a postmenopausal state. And we see that in those women who have been treated for their breast cancer, especially reaching their 7th and 8th decades of life, more of these individuals are actually dying from cardiovascular disease than their breast cancer itself. And then lastly, if I haven't kind of belabored the point enough, kind of a more recent study that was published just late June of last year showed that those patients with gastrointestinal cancers, after 5 years out from their diagnosis, the leading cause of death in this population was actually cardiovascular disease and not the cancer itself. So as I alluded to a moment ago, as we continue to see survivorship trends improve in this population, we are now seeing upticks in cardiovascular mortality and morbidity. So this has led to this basically marriage between our fields of cardiology and oncology and where this term has come from. So given these known cardiovascular mortality trends among cancer survivors, there's clearly a strong need to address this concern. And this has led to our multidisciplinary approach to how we manage this vulnerable population. Specifically, there's 2 main focuses in cardio-oncology. The first focus, which will be a large part of our talk today, is that there are certain cancer therapies that are excellent in helping improve survival, quality of life, what have you, for an oncologic population. However, some of these therapies do have a potential cardiotoxic risk, and that requires particular focus and monitoring. And we're going to go into great detail on that in a little bit. The other thing is some of our individuals that we see in clinic who have known cardiovascular disease or significant cardiovascular risk factors, whether it be high blood pressure, diabetes, what have you, are also receiving therapies that may be potentially cardiotoxic and may require closer monitoring in these circumstances. So the goal from the cardiologist perspective, from helping to manage an oncology patient, an oncology population, is we are trying to help survivors stay on life-saving or life-prolonging therapy as long as possible. In fact, we now know that there's data that says that if cancer treatment is interrupted due to potential toxicity to the heart, that prognosis is overall worsened. And so our goal is not to tell the oncology team necessarily when to stop treatment. It's to help patients get their hearts, get them, but get their their cardiovascular system through their treatment, and they can move on with their lives. A big part of this field is communication. I mean, I don't think this can be overemphasized enough. There are so many people involved in these individuals' care, from the oncologists and the hematologists. You have your radiation oncology teams, your oncological surgeon teams, our advanced practice providers, our nurse navigators. And I found that closed loop communication and how we manage these individuals cannot be overemphasized. And we'll talk about that in a little bit too. So when we think about the role of a cardio-oncology program, the first thing we think of, and I kind of alluded to it a moment ago, is helping to identify and prevent the initial potential toxicities from some of these cancer treatments. We say the primary prevention, because this is before people have actually developed the toxicity. We also think about secondary prevention. So once an individual has developed some early signs of potential toxicity to the heart, being able to rapidly identify and manage that individual is key to helping prevent further decline in heart function. Also, as a cardiologist, our goal is to manage those underlying cardiovascular disease issues that individual may have had even prior to their cancer diagnosis, as well as the cardiovascular risk factors, as I've mentioned. And then there's also an aspect of post-treatment surveillance. Is there some potential long-term sequelae of the oncologic treatment they received that may have a cardiotoxic potential? We obviously do not want to miss that. And we'll get into that in a little bit. So now let's talk about some of these specific cardiotoxic cancer regimens that we come across. So historically, when we've talked about toxicity to the heart, we've broken it down into two terms. Now, I'm going to tell you right now, these terms are a bit antiquated, but they are still used today. And I'm going to talk about them, and then we're going to kind of go into details of the other potential mechanisms. But I did want to mention these because this is a lot of the meat of what we see in cardio-oncology. The first of which is what we call the type 1 cardiotoxicity. Now, this is toxicity to the heart that's actually specifically, basically cancer treatments that can specifically damage the cells that make up the heart. Those cells are called cardiomyocytes. It can actually lead to necrosis, basically death of those cells. We are seeing these with a group of chemotherapy agents called anthracyclines, which are a excellent chemotherapy for select populations and are really the matter of prolonged survival and improved quality of life. However, we do know that there is this risk-benefit conversation, and we're going to get into that in a little bit. But sometimes when we do start seeing toxicity with these therapies, we see that it is somewhat irreversible, and subsequent doses of the anthracycline leads to basically worsened and worsened heart function. Compare this to the type 2 toxicity, which is typically a much more favorable process. And as opposed to actual heart tissue death, this is kind of more of an injury pattern, or basically kind of almost a lack of a better word. We sometimes say stunning. Well, that's not totally correct, but we know that this is a much more favorable prognosis. And we see this with some of the more novel monoclonal antibody therapies that we'll talk about in a moment. So let's start with type 1 toxicity. So what are anthracyclines? Well, these are a group of chemotherapy agents that work by two mechanisms to fight cancer. One of which is they inhibit the cancer cell's ability to repair its DNA. And they also allow for an overproduction of a type of chemical called reactive oxygen species that can be quite lethal to the cells, the cancer cells, and essentially cause cancer cell death. The issue, however, is these reactive oxygen species can sometimes also build up in heart tissue, and this can lead to the heart tissue dysfunction, heart tissue death, and eventually heart failure. Now, I don't want people to get concerned and think that everyone who gets anthracyclines are going to develop this. No, this is luckily a relatively rare thing, and we're going to talk about how we monitor this. First, let's talk about how we even define the potential toxicity that we see from this treatment. One of the most common metrics we use in looking at heart function is something called the ejection fraction, or EF, as I've written here. The ejection fraction is simply a measurement of how well the heart squeezes. It's a percentage of blood that the heart squeezes out with each heartbeat. We define toxicity from anthracyclines as a reduction in the ejection fraction by over 10%, and typically below 50% of what is considered normal. This toxicity, luckily, as I alluded to just a moment ago with anthracyclines, the most common of which is something called doxorubicin, is typically not seen with the usual doses of therapy that patients receive. For example, a breast cancer patient who receives doxorubicin may receive a total dose of about 240 milligrams per body surface area, which, by the way, it's kind of weird dosing, but that's how we talk about the dosing of these medications, is basically a milligram dose per their body surface area. But we know that the data for when we start to see heart failure does not really start to uptick. Basically, the toxicity doesn't uptick until around 400 to 500 or 550 milligrams per body surface area. So we know at these lower doses where it's pretty darn uncommon, essentially rare, to see toxicity. But when we start getting to these higher doses in select populations who frankly need them, this is where us as the cardiologists have to start being more vigilant about monitoring the individual's cardiac function. So how do we manage this toxicity once we start to see it? Well, some of the things that really can't be overstated, first of which is really thinking about the overall cardiovascular risk profile. Whether or not the individual is a smoker, has high blood pressure, diabetes, obese, what have you. And we really focus on trying to modify these lifestyle metrics. We also talk with our oncology colleagues about certain types of adjustments we can make to the anthracycline dosages themselves, which ultimately, at the end of the day, should be the oncologist making these decisions and not us as the cardiologists. But this is something that definitely we can help discuss with. From the cardiologist perspective, if we do start to see some early signs of toxicity or reduction in that ejection fraction, we can start getting individuals on certain types of heart failure medical therapies to allow for basically positive remodeling of the heart tissue to basically try to help re-strengthen the heart. And then lastly, there are specific antioxidant therapies that are sometimes used. Again, this is typically at the discretion of the oncologist and not so much the cardiologist. Now let's compare this to type 2 toxicity, which is overall a much more favorable prognosis. It's somewhat random in how it occurs. It seems to be dose independent. But typically what we see here is once the agent is removed, the prognosis is pretty favorable and heart function improves. Most commonly, we see this with a group of therapies that target a molecule called HER2, most commonly something called trastuzumab, or the brand name is Herceptin. As I stated a moment ago, these are basically monoclonal antibodies that target a certain receptor on cancer cell surfaces called the human epidermal growth factor 2, or HER2 receptor. And we see this in breast cancer populations and various esophageal and gastric cancers as well. And historically, individuals who had cancer that was HER2 positive, basically overexpressed, this was basically considered a much more aggressive cancer, higher risk of recurrence, prognosis was much more guarded. However, the advent of HER2 targeted therapies has completely changed how we think about survivalship and has really put a positive light in seeing individuals who are HER2 positive. Again, this is part of the reason when we looked at those cancer survivalship trends I showed you earlier, that we have seen improved survival over the last decade or so. There are now several additional HER2 targeted therapies, but for the purposes of this talk, I'll just focus on trastuzumab since it's still the most commonly used one. So how does it cause toxicity in the heart? Well, unlike the anthracyclines that basically lead to these chemicals that cause a lot of oxidative stress to heart cells actually also express HER2 on their cell surfaces. And HER2 in heart cells is actually responsible for certain types of repair pathways, especially during episodes of hemodynamic stress. And so what we've seen is that there will sometimes be reductions in heart squeeze, or the ejection fraction, as I mentioned, sometimes up to 10% in individuals receiving this therapy. However, it's typically asymptomatic, and these individuals oftentimes don't even notice their symptoms, although there are less commonly people who do develop symptomatic heart failure. As I mentioned a moment ago, this is a dose-independent mechanism and is typically reversible with discontinuation. And I apologize, I didn't really talk about the image I showed for the anthracyclines, but these are essentially cartoons outlining the mechanisms for how anthracyclines and trastuzumab or HER2 targeted therapies work in cancer cells to essentially prevent cancer cell proliferation. So there's now been numerous trials looking at the use of specific heart failure targeted therapies and basically preventing toxicity to the heart. And I'm not going to bore you with the details. Some of these studies do have funny names. There's the Prada trial, the Manticore trial. There's the SEER network that has published data more recently. The two more recent studies, I did want to just talk about briefly, the Scholar and SafeHeart trial, because both these studies came out, unfortunately, right before the start of the COVID-19 pandemic. And so I don't think they got the attention they necessarily deserved. But the SafeHeart trial is one I did want to briefly mention. This was a study published out of Dr. Anna Barrick's group at University of Pennsylvania. She's one of the leading cardio-oncologists here in the country. And this was essentially looking at those individuals who had basically breast cancer patients who had been on trastuzumab and had developed mild reductions in their heart squeeze, albeit were asymptomatic, which again, as I mentioned a moment ago, the majority of those individuals who do develop toxicity are oftentimes asymptomatic. And what they essentially asked was, if we get these individuals on neurohormonal inhibiting therapies that are basically used to treat heart failure, can we safely continue these patients' trastuzumab therapies and allow them to complete therapy, or is there going to be worsened toxicity? And what we saw was that 90% of these patients were actually able to continue therapy despite mild toxicity that had developed without any further reduction in ejection fraction or worsened heart failure. And this is a very positive thing, because now what we are seeing is even when individuals develop some early signs of toxicity, so long as us, the cardiologists, are able to get these individuals on appropriate therapies, obviously control their cardiovascular risk factors, we can continue their therapy uninterrupted. Because as I mentioned a moment ago, as soon as we start interrupting these therapies is really when prognosis starts to change and we give the cancer the best options to mutate and potentially cause further havoc. So there's all kinds of guidelines, and we'll talk about some of the guidelines at the end of this talk. But the American Society of Echocardiography has outlined guidelines. I mean, I can't believe how old they are now. I remember when they first came out, I thought how novel they were. But they essentially recommend that for those individuals receiving anthracyclines, that they receive echocardiograms to get a baseline. Echocardiogram, by the way, is ultrasound of the heart, which is the most common modality we use to look at heart function. They recommend getting the echocardiograms at the beginning of treatment, kind of throughout treatment, and then about 6 months or so after the completion of treatment. And those recommendations are somewhat similar for trastuzumab. The American Society of Clinical Oncology, or ASCO, has also published guidelines. These guidelines are now almost 5 years, I guess they are 5 years old now, looking at monitoring cardiac dysfunction in those patients who receive specifically anthracyclines or trastuzumab. AC here stands for anthracycline, but they identified certain populations that are at risk, and we've kind of already talked about some of these individuals who may be at risk, one of which are potential patients who might receive both anthracyclines as well as trastuzumab. And they kind of give similar recommendations to what I mentioned a moment ago in regards to modulating anthracycline infusions, using certain types of antioxidants. And they also recommend obtaining an echocardiogram at baseline as well as after completion of therapy. So as I kind of said earlier, I said there's these type 1 and type 2 cardiotoxicity definitions, but these are pretty outdated terms because as cancer survivalship continues to improve and patients are living longer, we're seeing more and more novel therapies that are allowing for that to happen. And with these novel therapies, these monoclonal antibodies, small molecule inhibitors, immune checkpoint inhibitors, what have you, we are also starting to see some potential long-term cardiovascular sequelae. And again, this doesn't necessarily mean that these therapies are bad or there's any nefarious intent here, because these therapies for these cancers are outstanding. I mean, they have completely moved the needle. For example, Bruton's TKIs, Brutinib has completely moved the needle in how we manage chronic lymphocytic leukemia. But we just have to be cognizant of these potential toxicities and kind of keep an eye on these things. And so I'm not going to dive into every single one of these. I have given that talk for oncologists and cardiologists, but today I maybe just wanted to highlight a couple of the ones that I've found kind of interesting and we've kind of looked into before. First of all, the fluoropyrimidines, and these are actually not new. These have been around forever. But fluoropyrimidines, specifically the two formulations we see are 5-fluorouracil, also known as 5-FU, and then the oral pill form called capecitabine or Xeloda. These therapies have been around for many years. They've been used to treat various types of colorectal cancers, select breast cancers, as well as head and neck cancers. However, they do have the rare but potential toxicities to the heart of driving up blood pressure, leading to certain types of arrhythmias, as well as causing spasm of the heart arteries, the coronary arteries. Luckily, these typically resolve with discontinuation of the agent. And we've actually published in the past kind of recommendations in how to manage this toxicity. Because if an individual does develop this toxicity, but this is the best therapy for them, it does not mean that it's absolutely contraindicated that they can't receive it again. I think we just have to have a careful risk-benefit conversation, look at other types of cardiovascular risk factors, and kind of optimize someone's overall health from a cardiovascular perspective before considering retrialing them with a fluoropyrimidine therapy. Next, let's look at high-dose interleukin-2 therapy. Again, not necessarily a novel therapy, but definitely a great therapy that has been used to treat various types of aggressive metastatic cancers, such as melanoma and certain types of kidney cancers as well. However, they kind of possess this myriad of toxicities that essentially mimic shock, as it causes all the vessels to dilate quite a lot and become quite leaky. And unfortunately, that can also lead to inflammation of the heart tissue itself, called myocarditis, which is quite a fulminant process sometimes, and basically should prompt immediate discontinuation of the therapy. We've actually published, our experience of this too in the past. And these are some circumstances where maybe it's not best to retrial these therapies. I just also briefly wanted to mention immune checkpoint inhibitor therapies because they have received so much excitement and again have completely moved the needle on certain types of cancers. These are a class of drugs that essentially help slick up the native immune system to essentially recognize and destroy cancer cells. There's a lot of names here. Most commonly we see nivolumab and pembrolizumab, also known as Keytruda, being used. And as I kind of said a moment ago, they have significantly improved survivalship trends and metastatic melanoma and certain types of lung cancers, and are wonderful medications. However, they do have this side effect profile that oftentimes can cause inflammation in various types of the body, whether it be the skin, the liver. But from the cardio-oncology perspective, again, what we get concerned about is this inflammation of the heart, this myocarditis. In fact, we are now getting involved in an international registry looking at the true understandings for incidences and management strategies for immune checkpoint inhibitor myocarditis. Let's just briefly talk about the effects of radiation on the heart. Well, radiation therapy, another therapy that completely has moved the needle for select types of cancers. About half of all cancer patients have received some type of radiation therapy. The issue is those individuals who receive radiation to the chest, the question always becomes, if there's some radiation that the heart gets exposed to, what is considered a safe dose? Where do we start to see toxicity? And that's always been a bit of a moving target to really understand, because data over the years has been a little inconsistent. Our populations that we look at have been a little inconsistent. However, I mentioned here the Darby paper. There was a study published, almost 10 years ago now, in the New England Journal of Medicine, looking at a registry out of Sweden and Denmark for left-sided breast cancer patients who had received radiation therapy. And what we saw was that there was a linear increase in basically developing cardiovascular events, starting as low as 1 gray, and gray is the unit of measure we typically think of in these individuals who receive radiation to the heart, with an uptick from there on out. So again, great therapy, completely moves the needle on individual's care, but just something, again, that us as a cardiologist have to be cognizant of when we're seeing new consultations. I won't bore you with the proposed mechanisms for how radiation leads to toxicity of the heart, but we do know that radiation can lead to some accelerated plaque buildup and hardening of the arteries. It can lead to some dysfunction of the very small microscopic capillaries of the arteries of the heart, and also can be quite damaging to the valve tissue in the heart as well, basically leading to thickening and fibrosis that can lead to both regurgitant or narrow, aka stenotic heart valves. So the American Society of Clinical Oncology has even put out specific recommendations on how to modulate this risk, including newer proton beam therapies, where you can actually target or steer the proton ions as opposed to the typical X-ray radiation, as well as something called deep inspiration breath holding. I just put in an image here from a review article that shows how essentially having an individual take a deep breath and hold it as they receive radiation to the left breast here shifts the heart completely out of focus, as you can see. So let's briefly just look at the role of cardiac biomarkers and imaging. So what are we doing here? What is the point of using biomarkers and this term subclinical? Well, the whole idea from our perspective as a cardiologist is we would like to be able to detect the earliest potential signs of toxicity to the heart before there's actually a clinical manifestation, before the individual has developed symptoms. And we have different ways we can look at this. A commonly used one is a certain type of imaging software on our echocardiogram machines. It's called global longitudinal strain, and we'll talk about it briefly. There's certain types of blood markers that we look at that are produced by the heart, the troponin and BNP being the most commonly used ones. And then just briefly, I'll also talk about some of the cross-sectional imaging, specifically a special type of special type of CT scan that can actually look at the heart structure and function. So let's talk about global longitudinal strain and echo a little bit and how this is an early marker for subclinical toxicity to the heart. So to talk about this, let's just briefly talk about some basic cardiac physiology. So what we do on an echocardiogram is we can essentially assess the deformation of the heart tissue as it squeezes throughout the cardiac cycle. We call this myocardial strain. It's a fancy term, essentially just looking at tracking the deformation of the heart tissue, as I mentioned. And we actually have specific packages, software packages that can identify unique acoustic speckles in the heart tissue and track it over time. And we can add this all up to create something called global, because the whole heart, longitudinal, because we're measuring in a longitudinal direction, strain, because it's the strain pattern of the heart. So strain, global longitudinal strain, serves as a very sensitive early marker for toxicity. And typically we will see the strain become reduced before the ejection fraction actually reduces. And so for those individuals who are getting echocardiograms to monitor for potential toxicity, it is now recommended that global longitudinal strain be included in those echo studies. And if anyone's interested, this is an excellent review article. Again, I'm plugging Dr. Barrick out of her group out of University of Pennsylvania. Great review article on understanding strain imaging at a high level in a cardio-oncology population. Briefly, let's just talk about some blood markers that are not used as often, I'd say, in a clinical level, but do serve some prognostic implication. This is an older study now published out of Italy, and it looked at those individuals who were receiving high-dose anthracycline chemotherapy. And they checked troponin levels, which is an enzyme produced by the heart. And if you see it in the blood, it implies there's been some injury to the heart. And as one would expect, those with higher troponin levels had higher cardiovascular event rates. And then lastly, I just wanted to talk about a specific type of CT machine that we use. The machine most commonly that we use lives at Providence St. Vincent, but this is a type of CT scan that can provide a lot of information in the heart. Not only does it provide information about the sac that the heart sits in, called the pericardium, but it can actually let us look at the coronary arteries, the heart squeeze function itself. It can serve as another metric when we may not be able to do an echocardiogram or don't have good windows with our ultrasound probes. And as you can see here, this image I pulled from online, we can see inside these coronary arteries. And so for those individuals who are maybe having chest pain or are concerned for plaque buildup, but may not be able to tolerate an invasive coronary angiogram due to all kinds of different reasons, perhaps they have significant anemias, what have you, from their cancer treatment, this is an excellent, suitable alternative. And we've published our recommendations and kind of a review on this in the past. So we're kind of coming to the home stretch here. Let's look at where we're at, I'd say kind of on a global scale, first of all, with cardio-oncology, and then where we're at locally with the Providence Heart and Cancer Institute with building our cardio-oncology program. So there has been numerous guidelines now over the last 5 to 10 years that have come out from various different heart and cancer societies. The American Heart Association, the European Society of Medical Oncology, the American Society of Nuclear Cardiology, American Society of Clinical Oncology, Cardiovascular, Canadian Cardiovascular Society, European Cardiovascular Society, Society for Coronary Angiography and Intervention, American Society of Echo. They've all published guidelines now in how to kind of manage and treat these individuals. And what we can also see, excitingly, is there has been a huge uptick in the amount of research that has been published using the term cardio-oncology just through a PubMed exploration. So where are we at locally? Well, when we first started building our program last year, we were reaching out to cancer providers through online meetings, emails, medical record communications, explaining what we were able to help offer for their patients and what we could do to essentially assist them in being able to care for their patients. As of March, we've now seen over 50 new in-person cardio-oncology consults since the initiation of starting the clinic, and we've received numerous non-visit e-consults as well. Most of our consults have come from Providence, but we're now receiving consults from Compass Oncology as well as OHSU. And starting next month, we will actually now start having dedicated clinic time carved out specifically for these consults. In the past, I've just been playing a lot of Tetris and trying to get individuals into my clinic as soon as I can. We're also building triage pathways for more urgent consults and also identifying a cardio-oncology nurse navigator to help manage this population. So where are we at? Well, because of the generous support, we have been able to build the Jack Loacker Center for Cardio-Oncology. And we've been able to put these funds in towards building medical directorship time for essentially being able to build this program, recruiting the cardio-oncology nurse navigator, obtaining certain types of diagnostic equipment, and you've kind of seen some of the diagnostic equipment I've talked about, building a more formalized continuing medical education program between cardio-oncology and cardiology and oncology. And then also from a research perspective, more on a clinical perspective, getting involved in registries as we have been doing, but also from a basic science perspective, becoming more involved in the multiomics of all of this. So together with the Providence Heart Institute and Providence Cancer Institute, we have a lot of excitement in where the Jack Loacker Center for Cardio-Oncology is going to be going in the next several years. I thank you so much for your guys' time, and I'm open for questions.
Thank you, Dr. Layoun. I actually do have a question that was asked of me by someone who couldn't attend today, but just curious, this seems like a fairly new collaborative discipline. Are there many other cardio-oncology centers across the country, or is this just one of a handful, or how many of you are there out there?
Great question. I tried to make my talk a bit shorter so we could have time for questions and people could have time for lunch. But I did have another slide initially that I had pulled off, and it was essentially a slide that showed where different cardio-oncology centers were being born out throughout the country. And yeah, in the last 5 years, there has been a pretty big uptick. More so, I'd say on the East Coast, but on the West Coast, we're now starting to see it as well. It's becoming more popular. Yeah.
And there was just one other question that I had, and I'm not seeing any other in the Q&A, so I'm just going to jump in here. You had a couple of slides on radiation therapy, and I know now it is more pinpointed, but back in the day, 20, 30 years ago, it wasn't uncommon to radiate the entire chest. And I'm just wondering, as a cardio-oncologist, are you seeing, are there less instances of radiation-induced cardiomyopathy, for example? Are you seeing more patients because they've been treated years ago with radiation therapy? What does that population look like for you right now?
Great question. And I kind of alluded to this a little bit and then kind of moved on because I didn't want to belabor a point too much. But I think the challenge of understanding the incidence of toxicity to the heart and really what thresholds for where we say enough is enough has been that there has been so many advances in the radiation oncology field, which I am not a radiation oncologist, so I can only speak to it to a certain degree. But being able to shift the heart out of the field of treatment, newer proton-targeted therapies, as I kind of mentioned, these clearly are going to probably have a positive effect on potential cardiotoxicity. But yes, for those individuals who had, say, Hodgkin lymphoma, who received mediastinal radiation, or left-sided breast cancer patients, we do see some of the long-term sequelae that may take decades to actually develop, but these individuals oftentimes will have pretty advanced calcific plaque buildup in their coronary arteries, as well as heart valve issues as well.
Thank you. And we are starting to get a couple more questions in the Q&A function here. So first question that came through on that function is, how are you educating primary care physicians?
Yeah, that is a great question, because that's what we would like to do from that CME arm. And that's where we like to start directing some of our funds, is to actually start opening this up, because most importantly, especially from that kind of primary prevention, that comes from the primary providers. Those are these individuals may be seeing their primary providers and may not be seeing a cardiologist at this point, and they don't necessarily need to see a cardio-oncologist or a cardiologist for that matter. But I think there is a huge area of growth that we can do to basically set up some formal education for our primary care colleagues.
Great, thank you, doctor. And a question about location. Is the Cardio-Oncology Center located at St. Vincent and Providence, Portland?
Right now, well, that's actually a great question. So right now, I've been seeing patients in person at the Oregon Clinic Gateway location and at our Gresham Clinic. But I've also been doing virtual visits, especially during the pandemic, which made that so much easier, where individuals lived all over the greater Portland area. We would like to eventually start developing a more stable location. And that's kind of one of our other goals of kind of building up this clinic.
Great. Thank you so much. I think I'm not seeing any other questions come through, so I think we're on the tail end here. But I want to assure all of you, if you have additional questions that come to mind, my information will be showing up on a next screen, and so you'll be able to reach me. I do want to say, and hopefully you heard from Dr. Layoun, that this new center and discipline is really only made possible through philanthropy. And it's been an incredible commitment to start this. To start this program had an initial $3 million budget. We were given a very generous $1 million gift to kick things off. But as you heard, we've got medical education goals to meet. We'd like to build an actual physical clinic and fill that with people and equipment that's needed to care for these patients. And so right now, I'm very pleased to announce that we have a $1 for $1 match going on. So between now and October 1, for every dollar raised toward our Jack Loacker Center for Cardio-Oncology, a generous donor will match it up to 1 million. And if we hit that goal, we will have achieved the 3 million in total startup we need to really help Dr. Layoun build a robust program for the Cancer Institute, the Heart Institute, and all the patients that we serve together. So if you have interest in learning more about that match, you want to learn more about the program, or you want to help share with others what's going on, again, my contact information is on the screen, and I'd be happy to follow up. And be assured too that we will be sending a recording of this presentation that you just heard to all of you as a thank you, and feel free to share that as well. So with that, just want to thank you again and remind you that this was the first in the 2022 series of Doc Talks. Our next one is coming up April 21st. It will feature Dr. Kevin Olson speaking about COVID. What have we learned in the last 2 years? Thank you again for joining us today, and I hope all of you have a great afternoon.
Thank you, Sherry.